Hello. Well, look, welcome to today's Homeless Health Community of Practice event. It's a great pleasure for me to be able to welcome you all to this first event in what's going to be a series of these get-togethers so that we can really focus our attention on the health of our homeless population. This series of events is going to tackle a number of different topics. So as you know, today's is all about mental health, really looking at what the needs of mental health are for our homeless population. But other events later on are going to look at substance misuse, for example, step-down care, primary care. So we're going to really have the opportunity to get into some of these quite tricky topics and really work together to see how we can do better. Now, as I said, today's focus is all about mental health, obviously a topic that is hugely dear to my heart. And we know that the needs are complex. So this is an opportunity to really step up our collaboration, step up our learning, and see how we can really accelerate the offer that we make to our homeless population. The community of practice and the events that we're going to be holding, this has been established so that we can gather together experts in the field, examples of really great practice, and make sure that we're sharing that widely. That will enable us to really enhance our experience, our understanding, our knowledge, and as I said, get a bit more rapid, get that acceleration in terms of how we can improve. And we want to use this opportunity to increase our partnerships and our collaboration. We have fantastic networks. You all feel passionate about what you do. This is a chance for us to really build on that and see how we can do even better. My reflections on mental health, for what they're worth, I think mental health, like so many parts of the health service, is at a really critical point at the moment. We've been through this amazing experience of COVID. We're incredibly aware of the impact that that's had on a number of our populations. The homeless population, of course, critical in that. What an experience they have had and what difficulties our staff have had right across the health service in stepping up and managing that challenge. So mental health is thinking all the time, how can we now, at this point in our journey, how can we build on the learning that we've had through the last year, through this pandemic? How can we step up to manage what is likely to be increased demand right across the piece, but also perhaps different, possibly more complex demand in some areas? And how can we allow that long-term plan that we're all busy implementing with our new community framework that's going to give us a real opportunity to work more collectively with the voluntary sector, the local authority, right across our system? How can we use that to help us in meeting that challenge? Perhaps the last thing for me is that whilst this is a period of huge change as we reflect on the experiences that we've had in the last year, and I don't at all underestimate the impact that our workforce have had and the weariness that there is. But as we reflect on that, the thing that I am most conscious of is that the passion and the energy and the commitment to this population, this such important, such a needy, such a vulnerable population, that commitment hasn't waned at all. I had the privilege recently to visit one of my services that has been providing support to the homeless throughout this last year, and it was really interesting for me to hear the experience that workforce had had. I heard at first hand how they had stepped up to the challenge when the homeless population locally in Camden was taken into a hotel, how they had immediately had to mobilise support to almost a doubling of their numbers in that very local patch and provide support to people who'd got drug and alcohol problems. I heard about the challenge some weeks later when some of those people decided they didn't want to be in the hotel anymore, and my staff told me how they had regularly gone out and walked the streets to find those individuals who they knew needed medication in order to keep them safe at a time when drugs weren't so easily available on the street, and not supporting them might have had dire consequences. Most interesting for me was, apart from their commitment, which always, of course, when I hear these stories, leaves me in total awe. But apart from that, what I heard from them was they had to do things differently, and that they had learnt from that, and that there were some of those differences they were now incorporating into the way they provide services going forward. So I know that right across London, those stories will be replicated. The stories of people going the extra mile, for sure, but also the stories of learning and innovation. And I hope that those are the stories or the experiences that you get a chance to share today at this event, and that from those stories we can really build how we can accelerate our progress and improvement going forward.
Right now, Huda is speaking up for the homeless population in the work that's happening around vaccination, and has been tirelessly advocating for them in terms of making sure that they're reached and have a sort of equivalent access to first and second vaccinations. But Huda has also led a really key piece of work looking at the need analysis of the homeless population. And it's from this needs analysis and this baseline that we will be able to think about how we plan services going forward. So just like to welcome Huda. Hope you're ready. More marvellous. Marvellous. Thank
There's
you.
no such thing.
For anybody who's joining, if they could just put their microphones on mute because we can hear all the lovely chat you're having. That's wonderful. Thank
I
you.
don't have access.
Can you see my slides?
Yep, I can.
Oh, thank you to everyone for coming here. I know how busy everybody is, but we're here to talk about a scoping review that we have conducted jointly at PHE with our partners. So the aim of the scoping review was just to provide a snapshot of the prevalence of mental health conditions among rough sleepers pan-London, to map out availability and accessibility of mental health services, and to highlight areas of good practice. I'm going to be talking fairly quickly because I have too many slides within the slotted time. But I just wanted to highlight that there is a strong and consistent association between trauma and homelessness, and being homeless itself is a traumatic experience. Compound trauma, multiple episodes with varying severity, frequency, and range of experiences impacts on mental health problems. So you get this vicious cycle of childhood trauma, mental health, and homelessness. If we look at the mental health needs and the prevalence of mental health conditions pan-London, the Find and Treat team at UCLH conducted a health needs assessment, which clearly showed that 50% of homeless people had depression and anxiety, 21% had problems with alcohol use, 16% had problems with drug use, as well as dual diagnosis. And this is based on self-reporting and is subject to reporting bias, and probably the prevalence of mental health condition is probably higher. So if we look at the literature, mental health issues are more prevalent among those experiencing homelessness compared with the general population, highlighting stark health inequalities. Some studies have shown that 80% of homeless people in England had mental health issues and 40% have been diagnosed with a mental health condition. High prevalence of neglect, abuse, and traumatic experiences not only in childhood but continue into the adult life. 70% of people experiencing homelessness in Scotland had at least one diagnosable personality disorder, and 40% two or more mental health problems. For women specifically, homelessness and mental health may be more prominent due to experience of sexual abuse, violence, separation from children, and breakdown of relationships. And there is a strong overlap between substance misuse and homelessness. Although psychosis is more prevalent amongst people experiencing homelessness, severe and enduring mental illness is not the main disease category. Most prevalent mental health conditions are anxiety and depression, complicated by complex childhood trauma and personality disorder, undiagnosed disabilities such as autism spectrum disorder, learning disability, and acquired brain injury, as well as substance misuse. So what we did, we mapped out mental health services in London, including outreach, counselling and therapy providers, IAPT, any self-care groups, as well as looking at referral pathways and criteria. And unfortunately, we do have very good services, but we have also identified gaps in terms of data capture. Homelessness is not always recorded. Gaps in activity in relation to those experiencing homelessness, as well as funding gaps. I'm just going to quickly go through these because we've done this through ICSs, and you will see all the red squares are gaps in services in different local authorities. But we also have very good revision in terms of outreach as well as mental health trusts. Same thing goes for North Central London. You will see some gaps in terms of counselling and therapy providers, rehab units, and self-care groups. So it's quite a complicated picture across London that needs to be addressed. Now, in terms of mental health provision, we know that it's a combination of mental health trust as well as RAMHP, EASL, and START, as well as voluntary organisations providing outreach work. And these slides have been kindly provided by EASL, who are going to be talking to you later on. So if we look at GP inclusion health, we know that there isn't consistent provision across London, but we have about 11 GP inclusion health scattered across London. So in terms of the challenges in terms of access to assessment and treatment, lack of engagement with services, potentially unpredictable behaviour, struggling with maintaining a relationship with one or multiple professionals, struggling with attending fixed appointments, needing to prioritise practical issues such as money, and maintaining their source of substances. And for people specifically with dual diagnosis, there's an absence of outreach services. Substance misuse itself can be a barrier to accessing psychological therapies, including IAPT, and persons needing to be registered with a GP. And many clients may not be registered with a GP, and most will not be able to receive letters or calls or emails. So in terms of the evidence on what really works in terms of mental health interventions, we know Housing First works. Evidence from evaluation of the scheme in 9 selected areas, 5 operating in London, has shown that improvements in physical and mental health among users. In terms of mental health, 52% of users reported bad or very bad mental health at entry into the scheme, which decreased to 18% after 12 months. In terms of evidence on mental health interventions, we know NICE guidance around prevention, early identification and assessment is key, as well as providing treatment and wraparound care, recovery and ongoing support, and we mustn't also forget end-of-life care. If we look at primary care and specialist services, a review of 14 European capital cities on homeless services demonstrated that generic services contributed more to providing long-term care, especially if there was positive engagement, whereas homeless-specific services were more responsive to the initial needs of homeless people with mental health problems. In terms of critical time intervention, which is a temporary measure of case management delivered in the crucial period of transition from inpatient services to community, can result in positive mental health outcomes with support from assertive community treatment teams. This model is obviously heavily reliant on outreach, and evidence from meta-analysis has shown that ACT for those with severe mental illnesses can reduce symptoms by 26% and homelessness by 37%. I can't emphasize the need for coordinated and integrated care. Co-occurring mental illness and substance misuse disorders is prevalent among this population, which can result in challenges in accessing relevant medical care. Integrated care in which mental health and housing are jointly provided to homeless population has been shown to have a greater impact than just providing mental health services alone. Early intervention and outreach, street triage services, mental health assessment should be routinely provided to this vulnerable population. Outreach workers, approved mental health professionals, ambulance staff, doctors, and police need to be trained around the Mental Health Act, and training also of the wider workforce and use of the wonderful voluntary sector, such as the Groundswell Peer Advocacy Service. In terms of access to assessment and treatment, outreach teams find it challenging sometimes referring clients to mental health services because person doesn't meet the referral criteria, insufficient evidence provided. Some will only accept referrals from a GP, and if a person has dual diagnosis, then that proves to be more challenging. In relation to staffing and resources, staff knowledge and skills is really important. Understanding the complex needs of those experiencing homelessness and trauma-informed care, and mental health professionals who are not homeless specialists may not be skilled to correctly identify those with mental health problems, including mobility of rough sleepers, is quite challenging. So what works in examples of good practice? EASL, I'm not going to mention that today in too much detail because Barney Wells is going to be talking to you about this. And they are responsible for enabling mental health assessments to be conducted, training and capacity building of staff and organisation, as well as encouraging reflective practice. We've got Dr. Jenny Drive, who's going to be talking to you from SLAM about a specialist mental health service in Lambeth, Southwark and Croydon, as well as the RAMHP team, which is hosted by Imperial and funded by GLA and MHCLG, have done some wonderful work across the 16 London boroughs by building teams of mental health practitioners that work directly with outreach services. In terms of good practice in London, we know that the London Borough of Redbridge have taken a making every adult contact count approach and employed a community mental health nurse specifically to work with RSMHT to support Redbridge homeless population who have been temporarily placed in hotels due to COVID-19. Redbridge have also provided funding for a lived experience peer support worker to work alongside the team and to support the work of rough sleepers. In terms of general practice, we know that Leicester City offers registration, for example, to homeless people and other marginalised groups and works in partnership with 2 hostels in the city to support and provide treatment to its residents. And the team is made up of experienced doctors and nurses, a liaison nurse who works between practice and local hospitals to improve the patient journey. So if we look at the NHS long-term plan, it's committed to spending up to £30 million extra over the next 5 years to meet the health needs of rough sleepers to ensure better access to specialist homeless NHS mental health support, and at least 20 areas with high levels of rough sleeping will be expected to have set up new teams by 2023-24 as part of the wider national rollout. And we are very fortunate that we do have standards of mental health provision, which has been kindly provided by Pathway Teams. And they mentioned that services should accept self-referral or non-health agency referral, having a combined approach specialist services that are flexible. All mental health services should be working with people with drugs and alcohol problems, mental capacity assessment, and removal of any geographic boundaries. And they also mention staff training in reflective practice, hospital in-reach, and regular outreach clinics in local hostels and drop-in centres. So what are the next steps in London? Well, the next steps are making mental health everybody's business with local leadership and champions, integration of housing and health, the power of services to transform and respond to this vulnerable group, flexible models of mental health care that are quality and evidence-based, EASL, RAMHP, expansion in primary care with support from specialist services, early assessment and prevention, to establish a pan-London clinical care pathway that promotes equity and avoids geographical boundaries, data capture and collection in terms of monitoring activity, integration of different services and organisations, mental health, local authority, housing, drugs and alcohol and primary care, as well as A&E and social care teams, training of staff in trauma-informed care and reflective practice, and how about the voice of those experiencing homelessness? So we hope to set up a multi-sectoral task and finish group to develop recommendation to meet the mental health needs for those experiencing homelessness in London. Thank you very much. I'll stop sharing.
Thank you, Huda. I think it's really clear from that presentation that we know exactly where the gaps are, and we've also got the best evidence to kind of fill those gaps. I'm going to introduce Barney in a moment, who's our next speaker, but Huda, Given the kind of the table you show with the traffic lights on it, or the kind of, you know, the gaps in services, what do you think have just been a couple of the barriers for local systems, local areas to getting those services in place? What would you think be the sort of two key barriers?
I think the two key barriers is actually understanding our population. Who is our population and what are their barriers in terms of accessing care? But also, it's really important to emphasize the importance of prevention and early assessment and identification and signposting to services. And I suppose the only way of doing that is by having an outreach and flexible model of service.
Yeah,
Thank you.
absolutely. Thank you, Huda. I'd just like to encourage everybody on the call that you are all key advocates for this population and often part of getting change in services about those who care most passionately, speaking up and sharing the information that informs the decisions. We will be sharing all of these slides back with you, so you can use that pack that Huda's put together with some really good information to take the conversation forward in your local area, and we'd really encourage you to do so, so that we can ensure that these things are prioritised for this population group. So I'm just going to introduce now the wonderful Barney Wells, who's Director of Enabling Assessment Services in London, which has got an abbreviation called EASL, E-A-S-L, if you ever come across it. So welcome, Barney. Lovely to see you. I'm going to hand straight over to you so we keep to time.
Okay. Hi, it's very nice to be here. I'm sorry I sort of have dipped in from a day of mandatory training and I'm not going to be able to stay around for much of the discussion. But I mean, to introduce EASL, we're a social enterprise, a community interest company, and formed in 2011, started in 2012. And really, my background was in the Camden and Islington Trust, where I managed the focus team and then a sort of a part of it which was left in Islington, which was then disinvested. And I suppose in 2011 there were three things which were apparent in terms of development. One was pan-London projects working with homeless people, No Second Night Out particularly. One was the development of the sort of psychologically informed environment sort of side of things. And then really the other thing at that stage was a disinvestment in specialist homeless mental health teams. And I guess the observation was there was still a need for that. And I think there was also, that was particularly apparent in the ambivalence from statutory services sometimes when they were hosting a project which worked across health commissioning boundaries. Since then, we've expanded and we're now the equivalent of about 9 whole-time equivalent practitioners, social workers, OTs, nurses. We have psychology input mostly for our own clinical supervision, and we also have some psychiatric input, which again, we largely use for our supervision. We provide three things: assessments, advice and capacity building to homeless organisations. And we're not equipped to provide treatment. We're not equipped to provide case management. We would always work alongside a homeless organisation, provide them the ability to offer the people they're working with an assessment by an experienced mental health practitioner, which might support them either to access secondary mental health services or sometimes to be able to make a case for example, that someone might meet the need for priority need, or to examine their housing, or maybe to support the person to reflect on what they've told us in the form of our assessment, which might be something they could take forward to working with a sort of therapeutic service in the future. But alongside that work with the sort of pan-London projects, we also are commissioned in some areas to provide by local authorities to provide capacity building. And that's the case in Hammersmith and Fulham, Newham and Westminster, where we support the homeless services they work with in terms of training, case discussion, and sometimes some relatively sort of discrete assessment work. And sort of finally, the other bit of the work we're involved in, we're directly commissioned by the GLA and we provide assessment and advice input to the outreach teams in the areas of London which don't have an NHS statutory homeless mental health service. So that would be START, Focus, JHT, or the RAMHP teams. I think in terms of the sort of challenges of our work, it's trying to sort of get that balance right, where we are very much committed to supporting the development of better statutory services, which can sort of offer ongoing treatment to people and that sort of liaison with other parts of sort of the NHS. But we're also continuing to recognise a need that's going to be better achieved if we're there without any sort of threshold for assessment, working alongside an organisation which someone might already be in contact with. And I think that gives us some advantages and some disadvantages in the way we work. I think as practitioners, we would all say that there's something very energizing about not having to decide whether anyone meets a criteria. We're able to offer an assessment to that person where they're at, in discussion with them about where their needs are at that stage, and we're able to be sort of open generally with someone saying, you know, let's have this conversation about where you're at, and then sort of establish what it is which we might hopefully able to use our assessment to do to help you. I think one of the disadvantages actually though is because we haven't got an ongoing relationship with the people who we're offering that input to, and also we're tending to see them at a point of sort of social crisis at very least, and sometimes coinciding with a sort of a mental health crisis, there is something quite difficult for us to structure in that sort of user's voice of the people we are assessing. And I think we continue to explore ways of improving that. A flip side of that is I think an awareness of that has contributed to us being fairly strong at incorporating that sort of voice of people with lived experience in some of the training we offer. And there's particularly a lot of work of someone who some of you may have heard speak, John Weatherall, who was previously a user of homeless and mental health services, as sort of effectively a part of the team, and very involved both in a lot of the training we delivered alongside Pathway through the mental health interventions and rough sleepers sort of toolkit, but also some more specific training around hearing voices and living with unusual beliefs. And most recently, actually, we did some work with some of the stakeholders from the RAMHP service and helped facilitate a day in which people with lived experience were able to reflect on what it felt like to be on the receiving end of mental health interventions as a homeless person. I think I've really sort of coming to the end of what we do. I think sort of moving forward, you know, I think it's a sort of complex situation for us. I think there does continue to be a need, especially whilst Pan-London services exist, for us to be involved in that assessment work, and there continues to be a need for that sort of that capacity building. I think our work with outreach teams and things, in some ways, the ideal would be for us to be made redundant in that reflection, in that regard, and for there to be those statutory teams working in every area of London. But at the same time, I do think there's also something that EASL has, based on our experiences, our historic experiences within statutory services, but also within EASL, of having some useful insights about how homeless services and mental health services can better understand each other's remit, work alongside each other's priorities, and I think sort of generally finding ways to try and sort of oil the wheels of people who are experiencing social challenges related to housing and excluded from some of the more the way mainstream services operate, the way their mental health can be better supported through that more joined up work. So haven't been keeping a very close attention to the clock, but I think that's probably a good point to stop. I'm not going for another 15 minutes or so, but then I've got to go back to my my other training session. But thank you for the time today.
Thank you so much, Barney. I'll ask if there are any questions. So if people have got any questions, just put your hand up. I'll give people a minute to sort of think about that. But what struck me from your presentation, Barney, well, apart from just the wonderfulness of the whole service and provider, was just you described there a level of integration and partnership and joint working, which is a key theme that we see through all of the sort of, particularly the specialist homeless health kind of services. But it must be very challenging to navigate all of those opportunities at different times, and certainly between the sector and where it kind of it finds itself, but actually across partnerships to sort of the big mental health trusts and organisations. And we've got new integrated care systems in London with a whole new set of actors. But it seems to me that the solutions to some of the things that Huda's put forward, and it's never to just create a standalone service. So there's something about how we create those relationships and connections across the system, and how we can use communities of practice and ways of doing that to help try and make that easier for people. If you had any reflections on that.
I think so, and I always think if there are mental health professionals, experienced mental health professionals who have an interest in sort of improving what is on offer for people who are facing social exclusion, there are sort of two broadly different approaches, and one is having specialist services which take on the work, and the other is to be involved in trying to improve the effectiveness of more generic mental health services and how they offer something which is sort of trauma informed and accessible to people who are in a sort of particularly difficult situation, but also trying to find ways of supporting those housing organisations to be better trauma-informed understanding of mental health. And I think it's about having a better quality of conversation between the different sectors. And I think there's something, I do quite a lot of training about the Mental Capacity Act, for example, and sometimes there might be concerns about someone who's street homeless, lacking, having impaired ability to make decisions about sort of housing. But it's vital in that situation that it's not just sort of clinicians, however well qualified, making decisions based on a sort of one-off assessment, but that they're able to understand the perspective of that person from those who've been working with them over time, for example, around housing. And it's just trying to make sure that that quality of conversation is maintained and you don't have problems. And actually, I think that's another area where things like reflective practice come in. I think that's how you manage to maintain a sort of sense of curiosity and an ability and an awareness of what other services are trying to do, and you don't get stuck in a bunker, start denigrating another service, or be more closed to understanding what their perspective is. I think we all as professionals also need to be sort of mindful of that and try and keep our minds open.
Absolutely, and so much of this kind of transformation goal for the homeless population is, as you've said, it's not just about creating the specialist services or the services who probably have the greatest knowledge and understanding, but it's that embedding it and getting all actors in all services to care passionately, as passionately as we do, about this population, and getting into enough dialogue with them that they can start to embed new practices in their own work. So thank you, Bonnie. It sounds like that's something that you're doing really successfully, and look to catching up with you again soon. And you talked about the RAMHP programme in your presentation. So that was a beautiful segue to the next speaker, or speakers, I should say. So we have the wonderful Christine Norman, who's an Innovation Delivery Manager, and Fiona Wallace, who's the Rough Sleeping and Mental Health Programme Lead in the RAMHP team. And that's so the Rough Sleeping RAMHP, not a skate ramp, it's got a H in there, it's got a health in there too. So I'm just going to pass straight over to them for their presentation now.
Thanks so much, Gemma. I'm just going to get my slides up, hopefully. Just bear with me one moment. Okay, let me know when you can see them. Hopefully they're up now. Wonderful, thank you. So thanks for the introduction. As Gemma said, I work at Imperial College Health Partners, where I'm Innovation Delivery Lead, and I've been leading the work on the RAMP programme, working really closely with the Greater London Authority for actually just over 2 years now, which has gone incredibly fast. And I can see from the people in the list of participants that actually there's a number of people who have been really supportive throughout this programme. So although I am presenting today, there are a lot of people who have been involved along the way, not least Barney, who is very supportive at the beginning of the programme in particular. So what I wanted to do today was just sort of talk about kind of what the programme is, some of the background to it and where it came from, and then what the RAMP services are actually doing, what they look like, and some of the next steps for it. So hopefully, there we go. So a little bit of background. This programme is part funded by the Greater London Authority and the Ministry for Housing, Communities and Local Government. And it came from a commitment in the London Mayor's rough sleeping strategy to provide some additional specialist support to people sleeping rough who have mental health needs across some of the London boroughs. Its overarching aims, sort of this aim is co-developed with people throughout the programme, is to help people with mental health needs who are rough sleeping take a step towards a better quality of life. And fundamentally, it's been designed to be around the partnership working. So not only multidisciplinary teams within the RAMP teams themselves, but just picking up on what Barney's just said, actually really trying to build relationships across the system to try and break down some of those kind of challenging systemic barriers. What I should say up front is it is a learning pilot, so it's a 2-year funded programme. So it's a bit of an opportunity to sort of test an approach, learn what works, what doesn't work, and then think about how we can spread that learning forward to future commissioning. And in terms of actual scope, it covers 16 London boroughs in across London, which is the geography of 4 mental health trusts. So it's pretty broad in scope, and kind of that does mean by definition it can't do everything, much as we would love it to. So yeah, there's always a breadth and a depth challenge with programmes, and this sort of is a broad programme of work, and we can go into that in a bit more detail later. In terms of the timeline, so actually I'm kind of giving a bit of a snapshot today, but an awful lot of work went into this in sort of February to September 2019, where we were working really closely with the GLA and a number of really helpful stakeholders and partners across the sector to understand what the programme could look like, kind of what are the problem areas, how should these be addressed, kind of how can we have the biggest impact with the opportunity available. And then there was a period from September to March when the trusts were sort of mobilising their teams. And then March last year was actually when the services went live. And that was quite an interesting time because, as everyone will notice, March also aligns with COVID, which was not in our original plans. So it has been quite an interesting year trying to launch this work in the middle of COVID. And it has kind of obviously changed things a little bit, but the team have done absolutely fantastic work to keep going despite all of the challenges of the past year. So that's the overarching aims and backgrounds. Before I kind of talk about the RAMP services, the actual teams, I'm kind of a little bit biased because I kind of work at the programme level on this, but I just wanted to highlight that one of the things we sort of wanted to do right from the beginning really was for the programme to really take into account the local kind of needs and approaches of the different trusts and the areas, because fundamentally, you know, that's every area is different. There's different services, different stakeholders, different population needs as well. So very much wanted to make sure that the services were co-developed by local stakeholders. But also wanted, on the flip side of that, to make sure that there was some overarching consistency across the 16 boroughs, across the 4 trusts, and that there was some sort of support there as well. So what we do have as a programme is what we kind of call the programme pillars, which are actually not just the service delivery, but also cross-sector relationships and cross-sector learning. So actively trying to encourage everyone within the programme to build those cross-sector relationships, to do learning together, and not just sort of formal training programmes, but actually that kind of social learning that happens when you're working across different teams on joint shifts together. There's also a shared theory of change. So although we have different trust level service designs, actually we've got an overarching approach that kind of spans the programme and some shared metrics as well. And then a sort of central coordination. So this is, I suppose, where we came in. So at Imperial College Health Partners, we were involved in the original programme design, and then were appointed to undertake sort of what's called a coordinator role. But that's essentially a bit of a backbone function to be there to support all of the 4 trusts, to provide some of the kind of supportive functions that helps everyone. So we've got a community of practice that we've been facilitating, bringing people together to learn about kind of challenges or to discuss, you know, what's happening, how are you dealing with this on the ground, especially during the mobilisation phase. But then also, quite importantly, I think we've brought together a small co-design advisory group, so people with lived experience of mental health and rough sleeping. So we've brought together that group, and then we work with them to support the local areas, so that the local trust areas, so that that voice of lived experience is fed in particular through the steering groups or through kind of pathway design, for example. And we also sort of helped with the GLA facilitator learning programme, which Barney, also Easel, did some of the work on as well, which has been fantastic. So this is our kind of overarching programme approach. I think it's just quite important. It's not that the 4 trusts have been kind of left to their own devices, although absolutely fundamental to delivering the work, but we've also tried to create some sort of support there as well, so that there is that kind of central focus on the programme aims. And then actually the RAMHP teams. So as I just said, they're all slightly different because they've been co-developed by the local stakeholders, so the trusts, the local authorities, the outreach teams in the area, but they do share some kind of key approaches. So kind of fundamentally, there's an element of assertive outreach. So the team go out and do joint shifts with the outreach agencies that are local to them, and actually that is the core referral route as well. So that really close working with the outreach agencies is just fundamental to the teams and the programme as a whole. There's also a focus on kind of navigation and advocacy. The teams are quite small, so the main kind of route to support, I suppose, is going out, doing assessments, mental health act assessments as well, and then supporting people to kind of get into the mainstream services, wherever that might be, depending on what the need is. There's only a very small caseload that might be carried as needed. The other, I guess, key thing to pull out is for 3 of the 4 teams, there's a cross-borough, like a single team approach that works across boroughs, just recognising that the population, you know, is often quite transient, firstly, but also when the teams are quite small, it can be quite helpful to have a kind of a multi-skilled approach within the team, and rather than being kind of having to work borough by borough, they can kind of spread the expertise across the boroughs as needed. So I think that kind of zooming out to a cross-borough approach has been by and large quite helpful. And then, as I said, multidisciplinary teams. So I've tried to capture here roughly what a RAMHP team looks like, although each one is slightly different. But by and large, we've got some mental health practitioners who go out and actually do the joint shifts with the outreach agencies, supported by a service lead or a service manager who are also doing the outreach as well. And then often some psychiatrist or psychologist time, usually to support the team. And then increasingly the teams are trying to bring in peer support workers as well, and then some teams have some admin support as well. So that's by and large what the RAMHP team looks like, and the kind of approach of each of the teams. Just conscious of time, moving on to next steps. So we are 1 year into the 2-year pilot, just over 1 year in. So the key question really on everyone's mind is how do we enable this to be sustainable after the pilot, so after March next year. We're also looking to capture learning sort of 1 year in, what have we learned, what would we do differently? If we wanted to spread this approach, how would we do it? And then there will also be an independent evaluation, not undertaken by us, an externally appointed one, again, to try and understand in more detail the impact that the programme has had and any kind of lessons coming out of that. So that is fundamentally the RAMHP programme. And like I said, I'm conscious I'm talking on behalf of multiple people who've been part of this journey. So thank you to all those, especially on the line.
Thank you very much. I was going to ask Fiona, what do you think have been some of the greatest benefits of the programme that you're seeing so far?
Hi Gemma, I can come in, but I think in terms of my role, it's not quite working with any kind of service delivery. So I'm Fiona. I also work at Imperial College Health Partners, but very much in this kind of coordinator role, so less of the kind of on the ground service delivery. So I think there might be some other people on the line as well. So if anyone else wants to jump in, I would encourage that as well.
Okay, no worries. If anyone wants to talk about that, then pop your hand up. I'll give you two minutes just quickly. But it sounds like from that presentation, one of your big challenges is coming, which is essentially that it's a 2-year funded programme. And as Huda showed, this is a really big gap in the sort of service needs that we've identified. So there's a big question, I guess, for integrated care systems and others working with that transition from a pilot that the GLA have primed and funded towards, if this is something that we think would be of value ongoing, how do we think about how we can sustainably commission something like this?
Yeah, absolutely.
So, yeah.
Oh, sorry, Gemma.
So as you go through the year, I mean, it would be fantastic to bring back some of that benefits realization before you get to the end and we're into pilot, and so we can start to kind of share that with people on this call and with the commissioners, so we can sort of talk about the value that it's bringing and also start thinking and planning ahead to next year's commissioning. So in the autumn, it'd be great to kind of reconnect and look at that together. Okay, I shall move us straight on then, but thank you very much, and great work there going on at the RAMHP team, and I'm sure people on the call have experienced that as well. So it's my absolute delight to now invite Jenny Drive, who is a force of nature in the mental health world of homeless health. She's a consultant psychiatrist, and with Fran Busby, she's here today from the South London and Maudsley NHS Foundation Trust. So over to you, ladies.
Thank you very much, Gemma. Force of nature is very kind.
I meant that in a good way.
Coming from you. So we've got some slides which are not slides that we use in various places, so they may not all be relevant. So like you said, coming up. Pardon? Are they coming up? Yes. Can you see us? Can you see our slides?
Not yet. Try again.
That's strange. Share. Oh, no. All right. Okay. Luckily, I've got a junior doctor who knows about things like this with me. So.
Junior doctor. Does she have a name?
Oh, look at this.
Yeah,
and then from here. Goodness me, can you see them now?
What we can see now is a sort of a file share screen saying we're opening your meeting in the Teams app.
Oh dear.
That's all right.
Yeah.
Luckily Esme knows what to do.
Hi Esme.
Hi.
Oh.
Someone's left and discussed. Can you see them now?
We've got you now, yeah. So you're on the second slide. So
John said,
perhaps just put it into slideshow view if you can.
Yeah. Slideshow. There?
Yep, wonderful, thank you.
Brilliant. Okay, well, as I say, we're just going to skip through these slides because some of it is teaching our grandmothers to suck eggs, I think. So with the START team, we've been around for years and years. We were set up in 1991 as part of a previous homeless mental ill initiative by a previous government. And I think the expectation, we were one of 6 teams at the time, and I think the expectation was that we would only need to exist for about 10 years. and then the problem of rough sleeping in London would be solved. But clearly here we are 30 years on. So we're part of the South London and Maudsley Mental Health Trust. We cover 3 boroughs in South London, Southwark and Lambeth, and also now Croydon. So Croydon, we only started covering in 2019. That was initially a pilot project, but now it's ongoing. So we've got a sub-team out there where I work a day a week. This picture, if anyone is wondering, is the shrine to the outcast dead in Union Street in Southwark. And I just like to have it as a reminder that that's why we do the work, because we try to stop people from becoming the outcast dead. As I say, I'm sure people know all this, but the average age of death of homeless people is 42. And this is to remind everybody of the trimorbidity. It's not just mental health, it's alcohol and drugs as well, and also physical health, which isn't on that slide, but it's another very big problem for our clients. So the more joined up working we can do, the better, I think. Our core team, I should say, or I'll just go back here and just say that we get our referrals from anywhere, really. So anyone who's concerned about someone, in usual times, that's usually mainly from the outreach teams and also from the day centres. So we normally do regular clinics in day centres in our borough, and we'll pick up people there. But we can get referrals from anywhere else, from police or probation or A&E or mental health teams, wherever it may be. And we'll work with anybody who's thought to have a severe and enduring mental illness that is thought to be keeping them on the streets. So people that need to be chain verified. So we need to know that they're in our core team. We need to know that people are sleeping out. And there has to be a suspicion that that's because of a mental health problem. And then we'll do an assessment and see what we think, and then we'll work with people to try to resolve it. I'm largely going to hand over to Fran. Well, just, yeah, again, a reminder that deaths are increasing, so there is a real risk of people becoming out. And lots of those reasons for dying are psychiatric, so drug, alcohol specific deaths and suicide. So those are all things that we as psychiatrists should be involved in. So I always say that we're doing the most important part of psychiatry. These figures I think you showed already. So those are the ones that we normally go on. 45% diagnosed mental health problems, but a lot of people have never got a diagnosis because they've never been in touch with a mental health team. So it's a slightly circular argument asking people, have you ever been diagnosed? Because someone has to have somehow either got to the person or they have to got to the team to get that diagnosis. And I'm going to hand on to Fran to talk about how we do what we do. Over to you, Fran.
Okay, hopefully you can see me because I can't see my video, but hello, I'm Fran Busby. I'm the service manager for the START teams, and I'm a social worker and an AMP by background, and I've been here for longer than I care to remember. I think it's pushing 20 years now, so a lot of time in homeless health. So the team is now comprised of about 18 practitioners in total. So we've got Jenny, obviously, we've got a consultant psychologist, we have got 4 social workers, including 1 other AMP apart from myself, 6 CPNs, 2 occupational therapists and a peer support worker and a nurse prescriber. So we've got the whole range of professions accounted for in the service. We offer the full range of interventions you would expect from a community mental health team. We do practical help for people around benefits and housing. We do assessment and care planning, medication, therapeutic interventions, and practical and emotional support. And one of the things I want to underline that's particularly important in this service, and why we feel very strongly that statutory teams are needed to support our homeless population, is the importance of being able to deliver those statutory interventions, mental health act assessments on the street, which we carry out together, mental capacity assessments, which obviously anybody can do, but we have a certain expertise in that, and particularly adult social care and their involvement with the rough sleeping population, which there are a number of challenges to. So we carry out in the START team our own safeguarding adult interventions, as well as care act assessments and provision of services thereon. And I think being able to do those with clients where we already have the relationship is particularly crucial, and making sure that those interventions occur. So how do we do it? Outreach, assertive outreach, I suppose, for those of us working in mental health. So we deliver the interventions I've described. We look at offering them in a place that works for the client. So we would see them on the street, in the park, in the day centres, at their hostel, if they want to meet in a cafe. So particularly in COVID, a lot of our work has been outdoors. We work at the times that work for people. If someone's a drinker, we might go and see them early on, or we might do work around whatever they need to do to make sure that we see them. Particularly crucial, and this has been touched on by a lot of people who've already presented, is the importance of collaboration, and that is obviously with our clients, but particularly with the third sector, so doing joint outreach. But also the START team has always provided support and advice to our third sector colleagues. So we have a duty line, people can ring up and ask for assistance and advice around mental ill health or crisis situations. We often end up supporting our colleagues in that way. We run clinics at the drop-in homeless day centres in all of our 3 boroughs, so we're able to meet clients and kind of observe people and respond to referrals from our partners. And we also facilitate strong networks with our statutory partners in housing, police and kind of primary care, and that advocacy role that the team has in making sure that our clients have statutory obligations met in terms of their accommodation, particularly people with no recourse to public funds. So there's a lot of kind of liaison advocacy work that goes on in the team, which I think is particularly crucial. And then, well, it's where we start really. So this slide is in the wrong order, but engagement. How do we provide a service to people that often are described as hard to engage? We keep ourselves psychologically minded. We think about the histories of trauma mentioned, particularly in presentation, that all the help we provide is relational. So it comes through kind of one person building that trust and that relationship with an individual client and providing services kind of almost within that one person. That there's a practical focus, that we kind of open that relationship by providing, you know, we can provide small grants, we help people do their shopping, we help people access housing, might be going out taking someone a sleeping bag or a thermos flask in cold weather. And we try and be as flexible as possible so that people can drop in and see us. Our office, people will turn up at kind of any time of the working day, not necessarily expected, and we'll do our best to help. Right, and then COVID, of course, has provided its own challenges. We don't need to talk to anyone here about everyone in. I don't think we're all aware of that. Jenny, did you want to talk a little bit about the work we've done during the pandemic?
I can do, yes. So we've covered hotels in our borough. So originally there was one in Southwark, one in Croydon and one in Waterloo. As I'm sure everyone knows, the one in Waterloo and the one in Croydon are still going. So we've had a lot of referrals from the hotels, and we have been going down there. There's me and our then junior Dr. Sophie doing clinics there once a week when it started, and we have kept that up. I think, is it 180 referrals we've had? For 180 referrals over the last year from the hotel. So that's been kind of the bulk of the work at times. And now I think the number, well, everyone knows the numbers of people who are out is going up again. So we're still getting referrals from the hotels, and we're getting more referrals back from the streets as well. And that's included in the hotels. It's included a lot of work with the HIT teams and the drug teams, so that we're sort of all working together. We've done mental health act assessments in the hotels, more than I think anybody anticipated, which has thrown up its own challenges, particularly, as I keep mentioning, because people were brought from all over London and put in hotels. They don't necessarily have a link to the borough. Most people don't. So then there's this ongoing problem about where people get admitted to, which is a sort of ongoing problem that we can talk more about if people want to. But it's been interesting in the hotels.
Have we got, Gemma, have we got time?
Oh yeah,
we'll mention our last.
Yeah, so just finally, when Fran mentioned that we've got a peer support worker and a opiate substitute, a nurse prescriber from the drugs team. This is part of our new sub team, which is very exciting. It's a pilot team from NHS England, which is working with people in the vulnerable adults hostels in Lambeth. So people, as opposed to our core team where people are on the streets, it's people who are housed and are thought to have coexisting mental health and substance misuse problems. So the people who everyone knows sort of bounce between services and potentially don't get a service from anywhere. It's been quite eye-opening, and again we can talk more about it, but it's often people who have been street homeless and might have been under our team when they're on the streets, or people who have been under other mental health teams and who for whatever reason have been discharged from them, but their needs are still very acute. So we've got me, only one session a week, it should be much more really, 2 excellent care coordinators, a peer support worker and a nurse prescriber who is seconded from the local drug and alcohol team. So it's real joint working, which has been very, I think, very instructive about how services should work, really. Our outcome measures so far are very good, particularly HONOS scores, which have shown improvement when people are working with the team. I was going to say something. Oh yeah, complexity. It is mind-boggling, the level of complexity, particularly I think in this client group. I think it's more severe even than people on the streets. We get a lot of acquired brain injury. We get a lot of ADHD, which has never been diagnosed. So there's a lot of work to be done, I think, with that client group, with creating pathways that people get the help that they need, which again, you know, brain injury work and ADHD tends to be static and not work by outreach. So I think we do need to think about how we can change that in the future. I think that's it.
That's great, thank you. And I know Angela McNabb is going to really enjoy watching the recording of this session and hearing about some of those opportunities and challenges that you've kind of identified. I was kind of interested in a bit of a sort of a side question about COVID, really, and from what you've seen and in the contacts you've had with people in the emergency accommodation, do you think there's been an improvement in mental health and well-being during COVID? Because obviously for all of us, it's been very challenging, hasn't it? Or do you think it's just really starting to open up the box of actually what's been hidden and invisible?
I think it can go in different ways, can it? I mean, certainly some people were pleased to get in and off the streets. Some people, it has to be said, didn't get off the streets and remained on the streets, and those people were maybe not thought about when the figures are being kind of collated. What I found interesting was there were a lot of people who were very, very unwilling to talk to a psychiatrist. Like at the beginning, I spent a lot of time in the hotels, and people
But
would
you're
say,
so friendly, Jenny. But you're so friendly. No,
well, I am very friendly, but people wouldn't speak to me. They say you're going to section me. So their only experience of people engaging with psychiatrists was to get sectioned, which is really quite sad. But if you think about why it is, it's because they're people who aren't going to go to appointments, are going to go to their G and will come from backgrounds where people wouldn't do that. I mean, whatever the kind of public health campaigns are, people don't have that. I'm going to go and talk about my mental health problems, and their friends wouldn't. Or if they did, they would get turned away because they also had drug and alcohol problems. So they just can't get a service. So they and their peer group, the only reason that they would come into contact with mental health services is when they did get detained, which is horrible. So actually, I think some of the best work that we did, and I was really keen that we did at least go and I still am, that we go and see people, whatever they were referred with, so that we could do a bit of kind of engagement work and say mental health services aren't just here to be punitive, we're here to help and see how we can help. And then I did have this slight anxiety that we were setting up people with false expectations, because the reality is that generic services won't go on working with people unless you're at a level where you need coercive treatment. People will say, you're drinking 5 pints a day, you can't come for psychological help, which is, you know, it's very sad. It's been eye-opening, the problems and also the level of trauma, astonishing level of trauma. So, you know, when you go in there and you hear story after story of people being neglected and abused from an early age, and just their lives all having a very similar and very upsetting life trajectory, and no one really doing anything to intervene, it's been eye-opening.
I think there was a really high level of acuity in there, as Jenny describes, but we're also coming across people that we wouldn't have necessarily done so without the hotels. So we saw a whole cohort of people, particularly with no recourse to public funds, not necessarily seeking asylum, but who've been surviving in the gig economy, maybe, you know, with a lot of social issues, using substances, and then their mental health really deteriorating to a point where, you know, we were doing repeated mental health assessments, there were repeated incidents. So the level of acuity was extremely high.
Thank you both very, very much. And thank you for the work that you're continuing to do. I would love to escape my lockdown kitchen and come and spend some time with your team. It just sounds like you're doing a fantastic job. So what I'm going to suggest we do now, so that's our speakers bits, and we haven't had a huge amount of questions in the chat, but I thought we should try and maybe have a bit of panel conversation. So what I'm going to do is ask all of the speakers to kind of put your cameras on so we can see you all as a sort of a panel, if that's possible. So if we could have Huda, Jenny, I think Barnaby's unable to sort of stay for this bit, but we should have all of the others. That's it. Great. Thank you very much. And what I'm going to do now is just kind of take us through then. So I'm just going to check if people have any questions for the panel, then please do just pop them in the chat box. I'll go and have another look. We've had a couple here already, and then I've got some sort of lines of inquiry to kind of run you through. So someone's just mentioned the no recourse to public funds, and particularly in relation to the sort of after end of June notice. And I think it's sort of it's an ongoing sort of London challenge that is growing, and actually the proportion in terms of the cases that you're probably all dealing with is growing as well, isn't it? And that's something that we're very much championing through the Rough Sleeper Strategic Group for London, which is sort of very housing led but combines housing and health together, as well as through the London Leadership Group. This is a challenge we're going to have to crack for London, and part of it is being part of the ending homelessness kind of work that's happening nationally. But I have a key question here from Caroline Shulman, and she's saying it would be amazing if the work that Lambeth are doing could be extended into other hostels. And we saw the pattern of your service there was sort of two big parts of London, wasn't it? And also if the diagnosis of severe and enduring mental health problems is seen as a real barrier for mainstream services to provide support for mental services. I think that's what you were saying, wasn't it, Jenny? So we've got, I think part of the challenge for population is the trimorbidity and the complexity. There's not a neat box, and therefore a lot of services find it very difficult on their access criteria to enable people to be participating in that service when there are already other massive personal access barriers to overcome before you can even get there. So, but without other questions, what I'm going to do is I'm going to go into a sort of set of kind of lines of inquiries I've been given to sort of put to you guys as a panel. So the first thing I'm going to talk about is the mental health assessments. Obviously, we've done quite a lot of mental health assessment, as I've heard, during COVID. But what do we think are some of the kind of, I guess, some of the sort of opportunities and barriers in terms of widening mental health assessments for this population? Any thoughts from any of you?
I think one of the things that's really important to say about assessment in this client group is that in our experience, it can't be a one-off piece of work, and then it has to be built upon the backdrop of engagement and again of relational work. So in the vulnerable adults team, and certainly in the rest of the team, we have a kind of general benchmark that we keep trying for at least 3 months, and that might mean, you know, weekly, twice a week appointment with someone that just tells us to sling our hook, that won't take the head out from under their sleeping bag, that, you know, and that will go on and on and on. So assessment as a kind of one-off piece of work is certainly something that doesn't work for this client group, and that assessment for us has to be very longitudinal and take place during the course of other interventions. So that, you know, going back to the providing the sleeping bag, and during the course of going and buying that together, you might conduct part of that assessment. So trying to go in and do those kind of in-out type arrangements, in our experience, really isn't helpful for the client or very particularly productive.
Okay, we've kind of had perspectives, haven't we, from a sort of an in-trust team as well as a sort of a mental health trust team. From a primary care perspective, now we know that sort of about 25% of this population aren't actually registered with primary care. Can you see any of the sort of the gaps in primary care services or ways that primary care could play a role?
Well, I think if Sarah Ketley were here, she would be able to speak to that very.
She might well be. I don't know.
So she, as you know, works at Great Chapel Street as a visiting psychiatrist, and I think a lot of people. I think she has a different experience where people do go and see their GP because of the way that GP practice is set up. So it's the same thing where Sarah's been there for years and years. People know that she's the psychiatrist, and that it's all about relationships, really, isn't it? And that GP practice is, you know, you can come in and someone will help you, and you can come in whenever without the kind of appointment times. And I think it's different from the sort of expectation that people aren't going to help. I think if people have a sort of, and word spreads so quickly in homeless communities as well, if somewhere has a sort of reputation for being a place that's going to help you, then it's quite different. So yeah, she'd be a good person to ask about it. But I think primary care services would have to be set up with this client group in mind. And they'd have to work in a slightly different way from how a lot of places work at the moment.
So we've got GPs in Lambeth, obviously, that have particular homeless commissions, and some of them will do outreach. So they'll be going into the hostels to see people, which is exactly the kind of intervention that's needed.
And know their patients very, very well and have a wealth of experience. And I think if they were here, one of their complaints that they would say is that then it's very hard when they think somebody needs mental health input. It's very hard to get the mental health trusts involved because they will sort of get knocked back and you're saying they're not coming to appointments. And so the GPs are left carrying this enormous level of complexity. Very experienced GPs who know when somebody needs help and they just can't get that help for their patients, which I think is quite upsetting for the GPs.
Yeah, upsetting and challenging, isn't it? And I think there's a huge amount of, I mean, we've seen in COVID, primary care really stepping up around vaccinations of inclusion health and other groups. And I suspect that sort of those gaps in ability to fully assess and refer for all inclusion health groups is actually probably quite challenging. And perhaps something we can explore with primary care as they've created many of those links through the work that they're doing now through vaccination and a much more kind of into sort of the outreach sort of process. Christine, you've got your hand up.
Yes, I mean, just to echo what's been said, but also I know it's one of the things that's on the mind of some of the RAMHP teams as well, which is building the links between the RAMHP teams and the primary care in their local area. So I think Jeremy might be on the line, and it's something that the West London team have been really focused on as well, and just supporting that development in the West London area between, not just the RAMHP team, but also the primary care as well. But also I think just more generally, there's some areas of London where the kind of community mental health transformation is happening, and the kind of bridging between community and primary care is undergoing a bit of a change anyway at the moment over the kind of next couple of years. And again, I think it's something the RAMHP teams are quite alive to, is how do we not get lost along that journey and make sure that we are also feeding into trying to bridge some of those gaps in the same way that kind of wider transformation work is trying to do. So completely agree, it's a really interesting
I wonder
direction.
if they've really tried to describe in one place, as a relative newbie compared to you guys in the sector, whether we've ever really tried to describe in one place a sort of a very joined up pathway with all the kind of key elements, so that there's a sort of maturity index for areas to work towards. And certainly that sort of dashboard, if you like, that Huda shared gives us a sort of a start of that. But to me, it seems that it's the kind of describing those services, the interplay, the flexibility and of them, both in terms of accessibility that we've heard, but also in terms of how the sort of fluidity of partnership between those different organisations is going to be really important. I don't know if that's Fran or Jenny who have their hand up, or whether that was an old hand.
I feel
old hand. Okay, I'm going to try just one more question because I want to make sure we get people out on time. So this one's about kind of the measures, really. Like, how would we describe, I suppose, at a high end sort of measure, what are the kind of key sort of things we want to say as a goal, really? What does good look like from a mental health care perspective? It might not be a measure, but perhaps just describing a bold ambition. And so thinking about what should care look like? What are the sort of elements you would like to see at every port or call for somebody who has access with services or who's receiving outreach? We've used the words trauma-informed quite a lot through the presentations. I'm wondering whether there's something about how we embed trauma-informed care much more widely and be leading champions of that, given the work that we're all doing and the population that we're with. I don't know whether, Jenny, you could talk a little bit more about trauma-informed care as a goal for all services.
Well, we're lucky in this team that we've got a psychologist who works with people from the outset and is very happy to see people on the streets. You know, and I think John's in the audience and he's probably able to speak about pre-treatment therapy, because it's so ingrained. I mean, there are different presenting problems, obviously, but trauma is so prevalent throughout. It's just impossible, I think, unless someone's got a sort of very straightforward psychotic illness that, you know, just needs some medication and well, it's never that simple. But most people have such, as I say, such long stories of intergenerational trauma, that makes, you know, engagement, that's one of the reasons that engagement is so hard. So we have to utilize psychologists, and everybody has to be trained in the trauma informed care, I think. But I suppose that's in our core team, where it's people with, there was a question earlier about severe and enduring mental illness, and you know, what's the cutoff? I think we could do, most people have some level of mental illness, and most people would usefully work with a psychologist or a counsellor. You know, as someone said at the beginning, ending up on the streets is itself traumatizing. So there's an infinite need, I think, for trauma-informed care, and we're only able to work with the people who are the most needy. I think if I were sort of organising services, I'd have an army of psychologists to go out to sort of, but they would need to go out. Sort of, someone asked about people not answering the phone. I mean, people aren't going to answer the phone, are they? You know, in the chat, someone asked about people not engaging with phone calls. But if you don't have a phone, you can't keep your phone, it's never charged, you don't have any credits, it's not really realistic to think that people are going to have going to prioritize phone-based assessments for something that they may not even acknowledge internally as a problem yet. So I think, again, it needs to be flexible and it needs to be outreach, and it doesn't, formal ideas of going in for some formal psychotherapy is just going to put people off. It has to be the way Fran described it, of informal, doing what you can when you can do it.
Yeah, absolutely. I mean, so not what we talked about the real importance of integration, haven't we? But actually, when I look at a lot of the assessments and the data and things that we're measuring parts of a person in different places. And so I think kind of moving forward as well, we need to think about, you know, what does a good holistic case record for somebody from this population look like, and how is it transferred and held and used around them, so that services are joined up across the sort of boundaries of the pathways that we can potentially create for people. So, well, it's been really kind of good to hear from you all, and thank you to all of the people who've attended today. I'm conscious of the time. I'd like to get people out sort of on time, but just thank you very much to not just for the presentations, but just for the fantastic service providers, and to all of you that we have in London, for all of the work that you've been doing throughout this COVID year, which has been extremely challenging for all of us. So just wanted to say a big thank you to you all while I'm here and able to. It's been an absolute honour to work alongside all of you, and to keep ourselves all going through COVID and delivering so much for this population. I think it sets a really strong foundation for what we can do next, because we have the ears, as I've said, of people. We have people within the policy circuit, within the region, the ears of commissioners and providers. Huge amount of attention has been brought to this population group, and we need to take advantage of that now and build on it, and just help them see what more we can do in the coming year. So I want to say a huge thank you. I want to remind people also that this is the first of a number of communities of practice. I think the next one, someone will probably tell me I've got it wrong, but is going to be looking in much more detail at primary care and the role that primary care can play in supporting this population. And the outputs and thoughts from this meeting are going to be taken into the leadership group, so they could be explored in much more detail.